Hi everyone, my name is John. Today we're going to talk about pharmacotherapy, which is using medication to treat opioid addiction. Um, a lot of people, a lot of medical professionals know very little about this subject. You'd actually be surprised. Um, and I think that is because there's a stigma involved with using medication to treat a drug addiction. Um, So for a long time, people have always thought, abstinence is it. It's either abstinence or nothing. And there has been a push in the recovery community to ease up regulations for medications such as methadone or Suboxone, and that's what we're going to talk about today. So we're all familiar with the current opioid epidemic that's going on in our country. But I want to give you some numbers just to chew on. So the U.S. Department of Health and Human Services found that in 2016, 116 people died every day from opioid-related overdoses. And that same year, 11.5 million people misused prescription opioids. That same year, 42,249 people died from opioid overdoses. And 948,000 used heroin. Of that 948,000, 170,000 used it for the first time. The economic cost is estimated at $504 billion. And that's a burden on our justice system, cost, prison system, our medical costs, just all kinds of things involved with economic costs. So the National Institute on Drug Abuse reported that between July 2016 and September 2017, approximately 21 to 29% of patients prescribed opioids for chronic pain misused them. Approximately 8 to 12% developed an opioid use disorder, and approximately 4 to 6% would eventually transition to heroin. During this time, opioid overdoses increased 30% in 52 areas across 46 states. So also during this time, the Midwest region saw opioid overdoses increase by 70%. States such as Ohio, Illinois, Kentucky, those are some of the hardest hits, along with West Virginia, New Hampshire, and so on. Opioid overdoses in large cities increased 54% in 16 states. And 35% of long-term patients being treated with prescription opioids meet the criteria for addiction. So the 5 states with the highest death rates that year due to drug overdoses were West Virginia at 52 people per 100,000, Ohio 39.1 people per 100,000, New Hampshire 39 people per 100,000, Pennsylvania 37.9 people per 100,000, and Kentucky 33.5 people per 100,000. Those numbers are insane compared to past years. So what are the benefits of doing an opioid agonist therapy, which is what a methadone maintenance program can be considered? So overall, it reduces overall drug use, reduces morbidity and mortality, reduces criminal behavior. Addicts don't have to go out and steal and rob, whatever they have to for their money, chasing money to get their drugs. There's an improvement in social functioning. No hepatotoxicity has ever been seen in using these, which means the liver isn't affected like with heroin or some other harder opiates. They tend to be really hard on the liver. Unfortunately, these medications don't show signs of that. There are no significant cognitive or motor impairments. Approximately 70% of opioid addicts tested responded well to treatment. So is this trading one drug for another? That's a big debate that we have going around today. It's been speculated that methadone is as much as 5 times more addictive than heroin. So common sense would dictate, well, why choose an even harder drug to get off a drug that's not quite as strong? And the answer to that is that methadone is a stabilizing drug. People that use heroin, because it's illicit drug, it's illegal, they have no idea where it's coming from. It could be coming from a different source every day, so the purity can change from day to day. It can be very low to very high, and whereas methadone is the same purity, pharmaceutical grade medication, and no longer do they have to go out and chase drugs and money. They this helps them stabilize their life, kind of returns their life back to them. No longer consumed with drug use and finding money for drugs. And methadone you become physically dependent on. And there's a big difference between physical dependence and heroin addiction. Physical dependence is, a lot of drugs are physically dependent, some worse than others, but physical dependence is not addiction, and there is a major distinction there. So methadone hydrochloride, it's a full agonist, which was developed during World War II by Nazi scientists. At the time, there was a shortage of morphine during the war, and Nazi scientists hoped to create a synthetic opioid analgesia. And what they came up with is what we call today methadone. It was originally called Dolafine, for Adolf Dolafine. It proved not to be very effective for the Nazis. But once the war was over, the U.S. seized a lot of medical trademarks and patents, and methadone was one of them. And there was a study done in '65 that reported success for treating opioid addiction or dependence with methadone. Instead of using it for pain, they attempted to use it to treat the opioid dependence, the heroin dependence people. So the original recommendations for treatment of opioid dependence with methadone was first that it should have an adequate dose, which they suggested at the time was 60 to 120 milligrams. Second was ancillary services. That they follow up with some type of counselor, some type of therapy. And of course, therapy was much different then than it is now. But it wasn't just a matter of, here, take this every day and you're fine. They did request that ongoing services were required. And methadone is designed to be a long-term treatment. It's typically not something that's done for a week or two. It's designed to be long-term, months, possibly years. So, methadone maintenance. Methadone works by activating the immuno-opiate receptors in the brain of an opioid-dependent person. Methadone diminishes cravings for opioids and prevents withdrawal sickness and reduces the euphoric sensation which accompanies opioid use. Because methadone is stronger and has a longer half-life, which is 20 to 55 hours, than other opioids, it dominates the mu-opioid receptors in the brain. So the longer a person is a methadone maintenance patient, as long as they remain a patient, the longer the half-life builds in their system, essentially creating a blocking effect against weaker opioids, such as heroin. So, methadone half-life formula. So I'm not a mathematician, and this is, to me, a rather complicated formula. But it's N times T equals N subscript 0 times 1/2 to T over 1/2 to the power of T. So let's break that down a little bit. The N times T equals quantity remaining after time. So the N subscript 0 is the initial quantity, and we're going to say 75 milligrams. And the time is going to be 48 hours. And the 1/2 to the power of T is the half-life, which we're going to say for this person is 50 hours. So what we have is a person that's taking methadone, 75 milligram dose of methadone for 2 days, and for their body they're metabolizing the methadone at about 50 hours. So after 2 days, for once a day 75 milligram dose, 38.55 milligrams will remain in the system of the patient. So this is just 2 days. So compound that with an additional 75 milligrams per day, every day, and the amount of methadone that will remain in the patient's system grows exponentially. Thus, essentially creating a blocking effect for any other full agonist like heroin or morphine. So the longer you do the methadone, the more the half-life builds up, which the more the methadone remains in your system. So, so after you've been doing it for a couple of years, you have, quite a bit built up in your system. And this is good for creating a blocking effect, but the problem with that is if a person decides to stop doing the methadone. This is where this long half-life formula or half-life time can be problematic, because the half-life of methadone can last as long as 90 days. So back to methadone maintenance. Methadone maintenance patient must remain under the care of a methadone maintenance certified physician during the course of their treatment. The state of Texas, the DEA requires that doctors that treat methadone have to attend a certain seminar and be certified. And for the first year, they can only have like 30 clients. And then the second year, it goes up to 50. And then the third, it's a little bit more. But and they only allow a certain amount of doctors to do this, at least in the state of Texas. And so this is problematic because a lot of states, there's a long waiting list for people to get on methadone. So the methadone, it must be dispensed by a nurse or a doctor. And the patient also must remain under the care of a licensed therapist or counselor. The patient must travel to the dispensing clinic every day. They ease up on this regulation after a client's been in the program for a couple of years. As long as they have been clean, they can get takeouts for like a week or 2 weeks at a time. So the federal government requires 1 year verifiable addiction history. I don't know, this can't always be verified. It is one of the requirements, but I don't think it's a deal breaker type requirement or something that's enforced too strongly. So the initial outpatient dosage for methadone should not exceed 30 milligrams. That's a federal regulation. And for every day they increase it a little bit more until they get to what they call a blocking dose, which is between 80 to 120 milligrams per day. Methadone maintenance programs work best for addicts with a large opioid habit. Because methadone is so strong, it people that do a lot of heroin per day, for stories of people with $1,000 a day habits, and that's a lot of drugs. They need something strong that's going to be even stronger than the amount of heroin they're putting into their system. And as they stay on the methadone, it builds up in their system, and these people with large habits, it's hard for them to stop doing it. And a lot of them might continue to use while they're on the methadone, while they first start methadone. But eventually that methadone is going to get built up in their system and create a blocking effect where they try to use the heroin. It's going to do absolutely nothing to them. Now, when methadone is used by non-opioid addicts, it can be dangerous. Also, when it's mixed with alcohol, when someone that's in a methadone maintenance program mixes it with alcohol or benzodiazepines, that can be very dangerous. It slows their, depresses their central nervous system and their respiratory system, and can be fatal. So, what are the benefits of methadone maintenance? So it reduces the risk of infectious disease by eliminating a patient's need or desire to inject opioids intravenously. It reduces criminal activities by eliminating the need of an opioid user to support a costly habit, so they're no longer out stealing. Overall improvement in quality of life. Now they're stabilized, they can work, go to school, function normally, and improves their social functioning. Addiction can be it's a very antisocial thing. In America, the word junkie has a very negative connotation to it. The word addict has a very negative connotation to it. And when they're no longer taking those drugs, they're going to become more socially aware, and it'll improve their functioning on a social level. So it also increases stability, eliminates withdrawal symptoms, and which allows patients to give their full attention to treatment approaches such as cognitive behavioral therapy. If a client is sick, having withdrawal sickness, or having strong cravings for heroin or pain pills, how are they possibly going to focus on treatment and what they need to accomplish through any type of therapy? It's just not going to happen. They're going to return to their drug of choice. So next we're going to talk about buprenorphine. Buprenorphine acts as a partial agonist at the mu-opiate receptors. It binds to the mu-opiate receptors and blocks opioid agonists such as heroin and pharmaceutical opiates, while simultaneously diminishing withdrawal sickness and any cravings for opioids. Now, what's the difference between a full and a partial agonist? Buprenorphine, when you take it, it immediately blocks, the first day you take it, it immediately blocks any other full agonist like heroin. So if someone takes buprenorphine and they leave and go to try to use heroin, they're going to have zero, it's going to have zero effect on them. Whereas methadone, if they take methadone the first day and then they go out and use heroin, they're going to have the effects of heroin. It takes time to build up that blocking dose with methadone, whereas buprenorphine, it's immediate. Now, buprenorphine can be combined with naloxone. Naloxone is used to treat overdoses. Medical professions will give people having like a heroin overdose, they give them the naloxone shot, and they immediately come out of their central nervous system depression, and usually they wake right up and their breathing and their heart rate, everything returns to normal. But so buprenorphine combined with naloxone is called Suboxone. That's the brand name. It was approved in 2002 for the treatment of opioid dependence. Naloxone, like I said, it's an antagonist, which blocks or reverses the effects of opioids and is used to treat opioid overdoses. So it's not like buprenorphine where you use it, it'll block the effects. It will reverse the effects of something that's already taken. So if they've taken too much heroin, they're about to die because their central nervous system is so depressed, the respiratory is so low, give them naloxone, they pull right out of it. Now, there's a reason they put the naloxone in buprenorphine, and I'll go into that in a minute. So the benefits of buprenorphine are similar to a methadone maintenance program, but much safer. Can be used to manage pain as well as addiction by acting as a full agonist for analgesia, while creating a ceiling effect for respiratory depression. Like I was saying before, with methadone maintenance program, methadone, people take too much of it or mix it with other drugs, and it can cause their respiratory depression, which can be fatal. Buprenorphine, on the other hand, you can't take too much of it like methadone and go into it. Has a ceiling effect where it will not happen. Buprenorphine patients can be prescribed Suboxone, which can be taken unsupervised, as opposed to methadone, which has to be taken daily in front of a nurse or a doctor. Also, buprenorphine patient or Suboxone patients they don't have to have the documented 1 year of opioid addiction. They can have less than 1 year of addiction history. Subutex. Subutex is the brand name for buprenorphine. It's taken sublingually, which is placed under the tongue and dissolved, and it immediately gets into your bloodstream that way, quicker than ingesting it. And it's used much similar way as methadone. When Subutex is taken as directed, it reduces cravings and withdrawal symptoms without producing the euphoric effects and depressed central nervous system, which are common with drugs like heroin or painkillers. Similar to methadone maintenance programs, Subutex must be taken under the care of a certified physician and must be taken daily. Does not have to be dispensed at a doctor's office daily, like methadone, but you still have to be under the care of a certified physician. Unfortunately, Subutex has a history of abuse. People will, patients will crush the Subutex pills and inhale it through their nose to get a quicker reaction, or they'll inject it intravenously. Some think they can possibly get high on it, and if a person is not an opioid addict and they don't have that heroin built up in their system, then they can get high on it. Suboxone. So much like Subutex, Suboxone contains buprenorphine, but with a small amount of naloxone, which we talked about, and it's also used the same manner as methadone. The naloxone's in place to prevent abuse of Suboxone. The buprenorphine is an agonist, while the naloxone is an antagonist. Even though agonists and antagonists oppose one another, the naloxone in Suboxone does not interfere with the effects of the buprenorphine. However, if a patient were to attempt to use Suboxone intravenously, the naloxone would reverse the effects of the buprenorphine and immediately throw the patient into what's called precipitated withdrawal. Now, precipitated withdrawal is can be described as like the worst withdrawal symptoms ever. It's very serious because withdrawal sicknesses coming off heroin or something is a gradual process. It builds and it peaks and then goes back down. Precipitated withdrawal immediately throws them into the worst withdrawal symptoms they've ever had. It's extremely uncomfortable, and it's probably I've been told, the worst feeling that anyone can have, period. So special considerations about methadone versus buprenorphine. Small percentage of patients are rapid methadone metabolizers, hence they do not do well methadone maintenance programs. These rapid metabolizers tend to perform much better on buprenorphine. Methadone maintenance programs tend to have a rigid attendance requirements, which can conflict with work or school commitments. Suboxone patients are not required to visit a clinic daily like those in a methadone maintenance program, and patients can fill a prescription for a 30-day supply from their pharmacy. Buprenorphine induction protocol to avoid the precipitated withdrawal, which is key to successful Suboxone introduction. For this to happen, it must be stressed to the patient that all opioid use must be stopped prior to the first dose of Suboxone. 16 hours for short-acting opioids such as heroin, 24 hours for sustained-release opioids such as oxycodone, and 36 hours for methadone. Now, transitioning from methadone to Suboxone requires a little bit different method. The patient must be stabilized on methadone at 30 milligrams and for at least 1 to 2 weeks. On the last dose of the methadone, it should only be 15 milligrams. The following day should be no methadone or any other opioid, and then the next day they begin their first Suboxone dose at a very low dosage. So, assessment and therapy requirements. Potential patients must meet DSM-5 criteria for opioid dependence. Patients must be given an initial assessment, a risk assessment, and a biopsychosocial assessment prior to treatment. Patients must adhere to all behavioral therapy requirements. Patients must be willing to adopt healthy lifestyle choices. Patients must commit to changing old behaviors and attitudes. And the patient must be at the third motivation stage of change. Before they once they decide they're going to go to a clinic, they should already be at the third stage, which is preparation. The preparation is by calling the clinic and making an appointment to go and start it. So once they've done that, they've gone to the clinic, they've started taking it, they are at the fourth stage, which is taking action. And rather quickly, they'll move on to the fifth stage, which is maintaining change. And as long as they stay in the program and do everything they're supposed to do with the program, therapy and whatnot, and stay away from the other drugs, they will remain in that fifth stage, which is maintaining change. So conclusion, there's no magic pill to cure addiction. While drugs like methadone, Subutex, and Suboxone are designed to reduce cravings and withdrawal symptoms, they're also used to stabilize the opioid dependent. When working with opioid addicted patients, before any type of behavioral therapy can begin, the patient must be stabilized. If they're suffering from withdrawal sickness or still having extreme cravings, they will not be able to focus on the next phase of treatment. Just like any other intervention approach, using medication to treat opioids is just one part of the overall process. Unfortunately, like other drugs, opioid users cannot quit cold turkey, which can be a recipe for failure. And that's one of the good things about these drugs is they don't have to go cold turkey and then suffer through the withdrawals and to begin their therapy, because that's just not going to happen for most of them. They're gonna return back to using before they even get to the therapy part. Most of them, not all, but a good majority of them. So these drugs will help them transition from an active daily user addict to someone in recovery and trying to change their life and have been stabilized off of whatever their drug of choice was. Anyway, that's all I have for today. This is my references, as you can see. I appreciate your time. Thank you very much.